Hey guys, so as I'm sitting here post-op from my mastectomy, my double mastectomy, I wanted to share some insight as to why did I have such a horrible experience at the hospital with these newbie nurses. And I'm talking, one of them was a nurse for about 5 months, the other one was 2 years, and the other one was probably around there, somewhere in the year and a half. And the critical thinking, guys, was so far off. Actually, there was no critical thinking. And I'm thinking, why? Why is critical thinking so difficult for these nurses? Why do they have no idea what to expect? And I was thinking legit nursing plans, right? Everybody complained about nursing plans, that they were so pointless, that they were so useless, but they're not. Now, what is pointless, what I do agree, is the hospital making us write 1,000, nursing plans a shift. That was stupid. But learning them is how you get critical thinking, because, they don't teach us everything in nursing school, right? You do learn most of the skills on the job, which is why they say give yourself a year to be a good nurse, at least, right? To start off, right? And then they have, your tiers of nursing, right? Like you're an expert by like year 5 or whatever it is, because it takes a really long time to see all the side effects. And it takes that long to see all the conditions and medical problems, to see them through, to see the medications through, to see all the side effects, what the expectations are, what the doctor's order are, right? And then after year 5, you start having intuition, and you start having initiative, and you start having gut feelings and things like that, and when to call the doctor, and you get to know people, right? But before then, you don't know anything. So in order to teach you what to think about is the care plan. So I'm going to do an example so that you guys can follow through of what could have happened to me if my nurses would have known their care plans. I have been a nurse since 2008, and I still have my nursing care plan book, okay? And I used to peruse it a lot because it's kind of a way of like reading about a patient condition and being like, okay, what's my role as a nurse? How can I help? What do I look for? Because yes, can your preceptor teach you that? Absolutely. But do you have a patient that has that diagnosis? What are the chances they come in with that? Very rare while you're in preceptorship, right? So you got to kind of do things on your own, and people need to take ownership of their career and their job. And you got to read, you got to learn, you got to take it upon yourself. You can't just depend on other people to feed you information. But for us to learn this for our own purposes, to know what to assess for, when you walk in a room with somebody who has an acute pneumonia, you go, okay, so I know he has risk for hypoxemia, I know he has risk for hypertension, I know he has risk for sepsis, I know he has risk for pain, he's gonna be coughing, right? Okay, now I know what my roles are, now I know what to look for, now I know what to implement, what to, have initiative for, right? So pulse ox, right? Like breathing treatments, antibiotics, cough medicine, are his respirations really fast? Are they not? What's his skin color look like? Can he walk? Can he talk? So all those things, all because now I know what to look for because of my nursing care plans. So I highly encourage you guys to, get a book and read it. Now, read it obviously for your floor. So if you're in a med-surg floor, you want to read what is relevant to you. So if you have most, let's say, post-surgical hips, right? If you're like on an ortho floor, you want to read, okay, what do I look for a post-op hip, a post-op knee? If you're on a regular medical surgical floor, so what do I do for anybody who had abdominal surgery, chest surgery, right? And they tend to kind of be the same, right? Everybody, surgeries per se, right? Risk for infection, pain, swelling, if they have drains, IVs, antibiotics, they kind of blend, but you will get used to it. But, of course, like a knee is different than a hip, so you want to know the difference. And then your typical floor stuff. So if you work, like I said, medical surgical, so you're going to have pneumonia, you're going to have COPD exacerbations, you're going to have chest pains, you're going to have, bronchitis, UTIs, whatever. So you want to kind of look for those things and learn. So I wanted to give you an example. Okay. So while I was in the hospital, I had severe pain, okay? Like unbelievable pain for me. And I would be telling the nurses, and they would only follow what was ordered, okay? Like could not leave that square of this is what the doctor ordered. I'm sorry, like this is what you get. And that is not how the world works, okay, guys? You gotta call that doctor. I mean, if it's not cutting it for the patient, you gotta call them. So word of advice, write down what you need to call the doctor for. Don't call them 5 times for 5 different things. Bunch them up. So if the patient is saying, I have a lot of pain, okay, do your assessment. Are their blood pressure fine? Are the drains fine? Does the incision look fine? You know, why the pain, and what do you want to do for the pain, right? You want to call the doctor with kind of like a purpose. Hey, you order this, it's not working. Can we do this? Okay. So I essentially had my JP drains pouring out blood, one of them. Okay. And I was, again, having severe pain, and they were ordering me morphine, 4 milligrams every 4 hours. And for me, it was only working for 2 hours. And the nurses were like, hey, sorry, that's what you get. I'm like, no, that's not what I get. Like, we need to figure this out. So they ordered me dilaudid PO for breakthrough. That makes no sense. It should kind of be the other way around, right? You give the dilaudid PO, you know, around the clock. And if they have breakthrough, you give an IV medication. So long story short, I ended up having to call the charge nurse and be like, this is not okay. And she goes, well, you know, if we give you the dilaudid and it turns on as we give you the morphine, you know, something bad could really happen. I have to protect my nursing license. What are you talking about? What do you think is going to happen? Okay. And the nurse was like, I can't give it to you because it's been an hour since I gave you a narcotic. And I'm like, okay, but I'm giving something PO for breakthrough. So that has to metabolize in my body. By the time you go and get it and give it to me and I digest it and it starts working, it's going to be at least an hour. And they're like, what if when I give it to you, it goes, you know, it mixes right with the morphine and it turns on. And I'm like, and what is it that you're expecting? Right? I am a young 37-year-old female with no past medical history other than this breast cancer. What do you think is going to happen? And see, you could have had your care plan there. Risk for respiratory insufficiency, you know, evidenced by desaturations. So maybe put a pulse ox on me. Maybe check my blood pressure. And then they're like, well, your blood pressure is low. No, my blood pressure is normal. We don't see a lot of those people with normal blood pressure. So like, your blood pressure is gonna tank. No, I have a fully functioning heart. I am absolutely healthy. My blood pressure is not going to tank. Is it going to drop slightly because I'm gonna be sedated? Absolutely, but I'm not gonna die, right? Nursing care plan, acute pain, okay? We're gonna read this, I know it's backwards, okay? But essentially, you know, your nursing care plan would be acute pain, secondary to post-surgical incisions, as evidenced by, right? Patient grimacing, patient complaining of pain, patient not eating, you know, patient mumbling, grumbling, okay? Whatever assessments you need to do. And of course, you can use a pain scale, right? 0 to 10. One of the main care plans is pain. Secondary to massive surgical wounds, okay? And I have my incisions here and I have my drains here. JP drains, okay? As evidenced by grimacing face, patient calling on the call bell, patient complaining, patient crying. Those are evidence that the patient is in pain. And then what do you do? How do you assess the pain? And then you implement your nursing implementations, right? You obviously give pain medication. You look for things around patients around you that you can improve comfort in, right? Fix their pillows, you know, have the call bell within reach, ice packs, heating packs, whatever you can do to improve the pain. Maybe use distractions. Maybe you want to play music. Maybe you want to turn the TV on for them, or, you know, their phone or whatever. I ended up with a hematoma on my cancer breast. And number one, no one ever took my bandages off to assess. She did not recognize that the output on my JP was higher than normal, and it was more sanguineous than serosanguineous, and never called the physician to alert him, hey, this is, you know, her pain is out of proportion, and she has a little bit of swelling on her right breast, and the JP is pouring out more than usual. Like, those are signs that something is going wrong, and that would make sense, right? I have increased pain secondary to a hematoma built up, and I had to go back to the OR to evacuate this hematoma. So unfortunately, it took 24 hours to figure this out, and luckily my surgeon figured it out, but the nurses could have caught this a lot sooner, okay? And now I have a wound under, where the surgery was, that has poor healing because now I got cut twice. So, this could have technically been prevented. Now, what ended up happening was that the doctor only ordered, certain pain medications. Like, for example, I was given 1 Percocet every 6 hours. Then I was given morphine, 4 milligrams every 4 hours, maybe 4 or 6 hours. And then I was given dilaudid PO for breakthrough. How does that make sense? It doesn't at all. So basically I would get, let's say I would get the 4 milligrams of morphine, which for me, it would only last 2 hours, but it was written for every 4 hours. So then I would need something for breakthrough. And so anyways, that is my baby hollering there because I can't hold my baby since I had a mastectomy. And also that proves to show some kindness from the nurses and show what a tough road I've had and I'm about to have when I get home, and they have no idea what it is about. And I don't blame them, right? It's like, if you know, you know. If you don't know, you don't know. But this was an oncology floor. So I'm sure I was not their first rodeo. I think that if you are a brand new nurse, right, and you are struggling to foresee problems, read a nursing care plan book just to peruse what is in your specialty. So if you're in a med-surg floor, read about surgeries, right? Risk for infection, risk for respiratory insufficiency, risk for sepsis, risk for pain, as evidenced by, right? And those are the things that you look for to prove that they're having that syndrome, right? So whatever, infection, so pus, redness, fever. Oh, and that's another thing, right? I spiked a fever in the middle of the night, and she's like, oh, well, let me give you some Tylenol. Why? Well, my fever was only 100.3. We don't want to mask an actual fever of 101. So no, I don't want any Tylenol. So that was a problem. I would say it's totally worth it on your downtime. Read a nursing care plan book that is relevant to your floor. Okay, so let's say med-surg, right? You have surgery, and obviously you have medical, right? So all your typical medicals, your pneumonias, your chest pains, your infections, right? Your UTI, your bronchitis, COPD exacerbations, all those things. And I mean, you would think that each infection is different, and for sure they have their own nuances, right? Because each body part is separate, a kidney from a lung, but it's all the same essentially, right? All infections all end up the same, right? All have high elevated white blood cell counts, all have fever, all have chills, all have some kind of redness, all have some kind of pus to the site, all have some tenderness, all have some pain associated with it, right? They all have some clinical symptoms that something is not right, okay? And then once you know that umbrella of symptoms, you know what to look for. Same thing for pain, same thing for exacerbation. Somebody's not breathing right. Somebody is hypotensive. Somebody is, desaturating, right? You'll know the cluster of syndromes to look for because it's all the same for pretty much everybody, right? So the care plans teach you those syndromes, and you'll become a better nurse for it, and your patients will thank you. And guess what? Your job will be so much easier. You're not going to go to work with those palpitations and anxiety, and every time the ER calls to give you a report, and every time you get an admission, you're like, oh my God, I have no idea what to do with this patient. But now you will.